This last topic that we're going to cover, exemplar acute pancreatitis, as well as chronic pancreatitis, is coming from chapter 54 of your Iggy Med Surg book. And everybody knows that acute pancreatitis is just inflammation of the pancreas. But what's happening inside of the pancreas that makes it resemble an autoimmune response or autoimmune disorder? What is the pancreas doing to itself? Autodigestion is occurring because of the excessive pancreatic enzymes. They begin to be secreted and they destroy the ductal tissue, they destroy the pancreatic cells, and this autodigestion will cause the pancreas to become very fibrous. Okay? Pancreatitis is caused by direct toxic injury to the pancreatic cells and the production and release of the pancreatic enzymes. What are some of those pancreatic enzymes that autodigest the pancreas? Lipase, trypsin, amylase. Okay? And after the pancreatic duct is destroyed or obstructed, then pressure may contribute to the ductal to rupture, allowing spilling of the trypsin and other enzymes into the pancreatic tissue. And then again, autodigestion of the pancreas occurs. What are some of the complications of acute pancreatitis based on page 1183? Pardon me? Jaundice is one of the complications that you will see. Do you see complications such as pancreatic abscess could form, or maybe a pancreatic pseudocyst? The patient on page 1184 may also have the complication of atelectasis, because if you're hurting in your abdomen, are you going to deep breathe? Are you going to cough? So atelectasis and pneumonia can occur. Because it is the pancreas and those ducts may be obstructed, you may have some coagulation defects and risk for bleeding to occur. Who knows what DIC is? Found on page 1184. Is disseminated intravascular coagulation.
Where your body uses up all of its clotting factor.
And you begin to free bleed because you've used up the clotting factors. So that is a side effect from acute pancreatitis, along with multi-system organ failure and shock. All of those are complications of pancreatitis. According to table 54.4, what are the most common causes of acute pancreatitis? Trauma. From what? Okay. Could be a stab or gunshot. It could just be a disease process going on with the pancreas being obstructed, or maybe it's obstructed with a tumor, or maybe there's cysts or abscesses that form. It could be renal involvement, or maybe it's inherited pancreatitis. Did you all know you can develop pancreatitis from taking diuretics? The loop diuretics can cause pancreatitis. Alcoholism can cause pancreatitis. Cigarette smoking, tobacco use, gallstones, cystic fibrosis can all cause pancreatitis. So when we are getting ready to assess the patient with pancreatitis, what history do we need to ask about? Okay, so we need to inquire if they're drinking alcohol, if they're having abdominal pain, We need to find out how much alcohol is consumed. Question the patient about any family history of alcoholism or pancreatitis or any biliary tract disorder. What will the physical assessment reveal on a patient that has acute pancreatitis? What will their assessment reveal? Jaundice, severe abdominal pain. Where is it going to hurt them mostly? Mid-upper gastric, left upper quadrant. Very good. Okay. And they will have some discolorations. I'm glad you brought that up, because when you see discolorations called Cullen's sign, where the blue discoloration is at the periumbilical area around the navel, that's a symptom that they're bleeding. If you see a gray-blue discoloration of the flank areas on the back, that's called Turner's sign. You really need to get vital signs whenever you see these two different discoloration, because the patient is most likely bleeding. So take vital signs to assess for hemorrhage. Also, the nurse is going to be careful in listening to bowel sounds. Absent or decreased bowel sounds could indicate that there's a paralytic ileus occurring. On light palpation, you may see or have the patient express abdominal tenderness. You're looking for any abdominal rigidity and any guarding where they're backing away from you, don't want you touching their abdomen. You're going to be assessing the abdomen for tenderness. Along with assessing the abdomen, you're going to always get a full set of vital signs and auscultate the lungs and heart sounds. You're auscultating the lung sounds to look for any adventitious sound or diminished breath sounds. All right. Laboratory tests. What does the nurse anticipate being ordered by the provider for pancreatitis? Okay. Okay, so she summed all of those up. And the two most important that you want to remember is lipase and amylase. Those are those pancreatic enzymes that's being secreted that are auto-digesting the pancreas. That lipase may rise later than amylase, but lipase will remain elevated for up to 2 weeks. So when the lipase and amylase are ordered together, you may see both elevated, or you may see the amylase elevated first. But up to 2 weeks, if that lipase becomes elevated, then you know that this patient does have pancreatitis. Amylase and lipase stay elevated for such a long time that the healthcare provider find this test to be very useful. And then again, if that pancreatitis is accompanied by some type of biliary dysfunction, or maybe there's biliary pancreatitis, then of course you're going to see the liver enzymes elevated, as she stated. Why would the ESR be ordered? What is that looking for? Erythrocyte sedimentation rate. It's looking for inflammation. Remember, CRE and the ESR are looking for inflammation. What would you expect with the white count? It to be elevated. Your textbook says that you may see a decreased calcium and magnesium level with pancreatitis, and it's usually associated with a poor prognosis. What imaging tests are done to confirm pancreatitis? Ultrasound, a CT, sometimes a plain KUB or that plain abdominal x-ray may reveal some gallstones as being the cause for the pancreatitis. So you're going to be concerned with relieving the acute pain, preventing any weight loss. So what would you expect the patient to receive to relieve their pain? What medicine will the nurse administer? Or what medicine, will the nurse administer? Okay, H2 antagonists and antibiotics, okay? And the main thing that you're going to do is rest the pancreas. Remember how we rest the liver, so it could regenerate and recoup? We're going to rest the pancreas now with pancreatitis. And the way we do that is by withholding food and fluid. We're going to keep them NPO. Everything that they get may be IV solutions or replacements. They may have to have a nasogastric tube inserted for feeding purposes, or they may have a gastric tube inserted to decompress the abdomen. They usually will hold off on putting in TPN if all possible. Remember, as long as the gut is working, they will use it. Okay? But what's the purpose in keeping the patient NPO? What triggers the pancreatic enzymes to secrete more enzymes that auto-digest the pancreas? Alcohol is going to release more pancreatic enzymes. Chewing and eating the food and digesting the food will create more pancreatic enzyme release. Any activity up moving, smoking, caffeine, all of that will increase release of the pancreatic enzymes. So you're going to see that patient fasting and rest. Drug therapy will be IV, and they're going to be resting the pancreas. So that patient will be resting with activity as tolerated. All right. What type drugs will they receive for pain? Morphine or Dilaudid, or they may have IV or the transdermal fentanyl, or epigastric analgesic type given, or epidural analgesics. Other medicines they may have is the H2 antagonists you all mentioned, famotidine, in some of the proton pump inhibitors like pantoprazole may be given, and then antibiotics. Which position helps them to rest better? The side lying position with the legs drawn up to the chest will help the abdomen pain. Or sitting with the knees flexed towards the chest is also helpful for the abdominal pain. If the patient is NPO or has an NG tube, remind assistive personnel to implement frequent oral and nares hygiene to keep the mucous membranes moist and free of inflammation and crusting. One thing about patients with acute pancreatitis, because the pain is up high epigastric, they don't want to deep breathe. So what does our action alert box tell us? Provide oxygen to promote more comfort in breathing. And the complications that you're monitoring for is like pleural effusion, fluid overload. You want to listen for any crackles, observe for any dyspnea, and monitor for any signs of respiratory failure. Now remember, we talked about that your textbooks say that the patient with pancreatitis may develop some decreased calcium levels, decreased magnesium levels, so you're going to be monitoring them for any electrolyte imbalance, which is going to be that muscle twitching, numbness, and irritability. Is pancreatitis treated with surgery? Usually surgery is not indicated unless they're having to remove some gallstones, or if they have to go in laparoscopically to remove the gallbladder, if there's gallbladder obstruction, things like that that's causing the pancreatitis. Nutrition. What are the nursing interventions expected with nutrition? Improving nutrition and promoting nutrition for the patient with acute pancreatitis. Okay, you're going to give antiemetics for the nausea and vomiting. So what will we provide for them? Enteral feeding is preferred over the TPN because of the glucose elevation and because of the lot of complications that could occur. But you would make sure that you would weigh this patient every day. So you're going to monitor intake and output. You're going to educate the patients on the importance of abstaining from any alcohol and encourage them to relax. What type foods will they begin eating once they are able to tolerate meals? It will be bland, but what type? Okay, why do they need high carbohydrate and high protein? Energy, what does protein do? Helps with healing, okay? And what foods should be avoided? GI stimulants such as caffeine, tea, cola, coffee, chocolate, as well as alcohol. All of those should be avoided. Okay. Now let's go into chronic pancreatitis. What's the difference between chronic and acute pancreatitis? Chronic has remission and exacerbations. Chronic is from alcoholism. That's the most primary risk factor for chronic pancreatitis. Most patients with chronic pancreatitis have decreased pancreatic secretions and bicarbonate, so pancreatic enzymes must be given to them in order for them to digest their foods and for absorption, for their body to be able to absorb their food. They have a lot of fat malabsorption, which makes them lose weight and have muscle wasting. In fact, they're the ones that's going to have what type? Foul-smelling stools. What are those stools called? Steatorrhea. Okay? And that's what you're going to be assessing for. What will the patient with chronic pancreatitis report as their symptoms? Besides the clay-colored, smelly stools, fatty stools, what else will they report as symptoms? Abdominal pain. They may have ascites. They may have jaundice, dark urine, symptoms of diabetes. Because what does the pancreas beta cells do? Okay. So how is chronic pancreatitis diagnosed? what 2 lab tests will be done? Labs drawn. One stays elevated 2 weeks, the other doesn't stay elevated as long. Amylase and lipase, they're going to use those same tests, and when they do some imaging, like the endoscopic retro colon angiopancreography type test, the ERCP, it will show, it will visualize that pancreatic and common bile duct, and it's going to probably show changes that have occurred with the pancreas. And it will show that this is probably chronic pancreatitis because of they may have some obstruction of their bile duct. Now, how will it be managed? How will we take care of this patient with chronic pancreatitis? So we're going to still be concerned about keeping them pain-free with opioid analgesics. We will. Okay. And there's one thing that's going to be added to this patient's plan of care. We have got to provide some pancreatic enzyme replacement therapy. And page 1190, what's the enzyme replacement for the patient with chronic pancreatitis? How are you going to prepare that patient to take these meds? Okay, take them with meals and snacks with a full glass of water. Administer the enzymes after they've taken their H2 blocker. Swallow the tablets or capsules without chewing to minimize oral irritation, and the drug needs to be released slowly in their system. If they can't swallow the capsule, they can pierce the gelatin casing and place the content in applesauce. Don't mix the enzyme preparation in protein-containing foods. They need to wipe their lips after taking the enzyme to avoid skin irritation. Don't crush enteric-coated preparations, and follow up with all scheduled lab testing. Okay? So you be sure that you know that information about enzyme replacements. Because this patient has had chronic bouts of pancreatitis, they will probably develop diabetes mellitus. They are also at risk for developing pancreatic cancer. Okay? How many calories a day does someone with chronic pancreatitis need? 4,000 to 6,000, it says. 4,000 to 600 calories to maintain their weight. And again, their food is going to be high in carbohydrates and protein to help with the healing process. But high food in fat is avoided because it could increase their diarrhea. Now, they will sometimes have surgery depending on if they have complication of that pancreatic abscess or the pseudocyst. They can have surgery to remove it, or if they're having gallbladder problems that's causing obstruction, then they can have a laparoscopic cholecystectomy done, or cholecystotomy, where they would remove the pancreas. What questions do you have about acute pancreatitis and chronic pancreatitis? With all of these exemplars, it's important that you know what the disease process is, how to recognize the signs and symptoms, what kind of labs would be monitored by the nurse if you were on the floor taking care of that patient, and then the nursing interventions. What does the nurse actually do at the bedside? What questions or comments do you have? Okay, we will start with the case study on pancreatitis.